Hi, everyone. This is Dean Hutchison from Circle Surrogacy, and all our panelists are in. We're just going to wait a couple minutes to go live so the room can populate as much as possible before we begin. So probably in like 3 or 4 minutes, it will get going, and I'll be back in touch to start right when that's ready to go. So talk to you soon. Hi, everyone. Just for anyone who's joined recently, we're going to begin in about 2 minutes. We just want to let as many people as can that registered to get in before we get going. So we'll be starting in about 2 minutes. Thanks. Hi, everyone. We're going to get going. Thank you all for coming and spending the evening with us. Tonight, we're going to give you a webinar on surrogacy and IVF in the United States. As I said earlier, I'm Dean Hutchison. I'm from Circle Surrogacy and Egg Donation. We have two amazing doctors with us from ORM Fertility, based in Oregon and Seattle. Before we begin, I just wanted to go over a couple of the ground rules and some background information. So currently you're in listen-only mode, and you will be in listen-only mode the entire time. But you can and will be able to ask questions. If you look to the right of the screen or wherever your go-to webinar control panel is, you'll see a question box. You can populate that throughout the entire program. We're going to save the questions for the end, and we'll go through all of them. But you can, if something comes up in the middle of when one of us are talking and it springs a question to your mind, just send the question in and we'll get to it. We are recording this webinar, so if you have to leave early or if you come late, don't worry, it'll all be uploaded and sent to you within a couple days. So if you ask a question and it doesn't get answered before you leave, we'll answer all of the questions at the end, and we'll get the recording out to you. So as I said, we have 4 panelists on tonight. I'm Dean Hutchison. I'm an attorney. I'm the Director of Legal Services at Circle Surrogacy and Egg Donation. With me is Dr. Brandon Bankowski from ORM Fertility. Dr. Bankowski is based in the Oregon office. He's a board certified reproductive endocrinologist with years of experience in the IVF field. Also, Dr. Jamie Massie, who is board certified OBGYN and reproductive endocrinologist, and she's based in ORM's Bellevue Clinic. And then finally, Nancy Weatherby, who's an IP, intended parent outreach manager at Circle Surrogacy and Donation, and she's also a parent through surrogacy. So we'll talk a little bit about Circle Surrogacy and the agency and the legal process and our whole surrogacy process, and then you'll hear about ORM and IVF and the IVF process, so you'll get a whole kind of full picture of legal, the process side, as well as the medical side. So the agenda I just meant. So we'll talk about working with an agency, a full service agency. We'll talking about kind of the legal, insurance, financing costs. We'll talk about the surrogacy process. We'll talk about the medical aspects of IVF and surrogacy, and then we'll talk a little bit about probably what's on a lot of people's minds these days, which is the COVID-19 aspect of how it's impacting surrogacy and IVF at the moment. For those of you who don't know Circle and you're doing your investigation, so we're one of the oldest and probably biggest surrogacy agencies in the country. I think we're going on 25 years right now with over 2,100 children born. We are what's called a full service agency in that we have donors available, we have surrogates, we have a legal team, we have a social work team, we have an accounting team. So each person has their own little individualized team, but it's all centralized. So you don't have to go outside to get some of the experience we have. As I mentioned, we have over 25 years experience. We have a full staffed legal team. We have many different members of our staff that are not only parents or surrogates or egg donors or have done IVF. So everyone's kind of has over 40% of the team has a fully vested interest in this process just from their own experiences. We have different programs. We have fixed fee. We have unlimited things, so you can make the process yours. And we just have a huge support network. We have different groups online. We have different IP support groups through Zoom, through Skype. We do reunions, we do meetups. We have all these different areas where we want the parents, the surrogates, and the donors to feel fully supported throughout this process. And we have our own, every surrogate has a licensed social worker attached to them, and all of our intended parents have a support network as well. And Nancy will get into that in more detail in her side. So from a surrogacy 101 perspective, we'll talk about a couple different aspects. So the first is legal, and as I mentioned, I'm a lawyer. I'm the director of Circle's legal team, and we basically Circle was founded by John Weltman, who was a parent through surrogacy with his husband Cliff Atkins 25 and 24 years ago, and it was kind of organic in that John was a practicing attorney. He was one of the first gay couples to do surrogacy where both dads ended up having a child of their own. So a lot of people would just come to him and ask him how he did it, have help with legal work, have help with finding surrogates, etc. So really it just began, I don't want to say a side job, but it wasn't John's specialty, and he was just helping parents out through the process. And then, I started with John now 16 years ago, and was probably doing about 20-30% of my time in surrogacy, 70% or so in just general litigation. And during that first 5 years I was with John, Circle just kind of exploded and basically consumed his professional life to the place where he separated Circle from the law firm and then brought a chunk of the law firm with us. So we have a fully staffed 9-person legal team at Circle dealing with the cases. From the legal aspects of things that are really important, number one is the applicable law. So the law most important to this process. And that's going to be where the surrogate delivers. So sometimes your state can come into play, or maybe where the IVF is done, but usually you're dealing with the law of the surrogate's delivery state, because that's the law that's going to create your parentage rights, create your birth certificates, et cetera. So we're really focusing on that law. We don't take surrogates at the moment from 3 places: Louisiana, Michigan, Nebraska. They either have really intricate bad surrogacy law or they have anti-surrogacy law. Michigan does have pending legislation, which hopefully in the next year or two will come to fruition, just like New York came off this list last week. But currently those are 3 places we stay away from. Contracts, obviously very important. There's going to be contracts with your agency, contracts with your surrogate, contracts with your IVF clinic, with your donor, and it's really important that you have, skilled attorneys, whether they're from your agency or from outside, that have knowledge in this area when they're doing the drafting. So it's important just to have that. Surrogates and egg donors are going to have their own independent attorneys as well, and again, important that they use an attorney that has a background in surrogacy or egg donation so that they're getting full representation throughout this process. Another important thing is to secure your legal rights. Obviously the most important part of this whole process, and that's just done by properly matching you with a surrogate in a state where you're the fully protected parent, where you're going to have certain decision rights, where you're going to have all these things, and that whatever specifically you need from a citizenship or a residency or any other things that you particularly want from a legal perspective can happen in that state. And then at the end, obviously, it's managing that parentage work in whatever state you're matched in to make sure the legal work is done properly in a timely fashion. So when the birth comes, everything's in place and you're not having any issues with the delivering hospitals. And the other aspect is to make the pregnancy your pregnancy as much as possible. Obviously, you could be miles and miles away from this surrogate and she is the patient and carrying the child, but we want to make sure that you feel fully informed and having decisions throughout the process, that if issues arise, you can speak with doctors and get medical records, et cetera. And when it comes to the birth, obviously, you're the first people in that room making decisions for the babies. Very important to all these processes is really the kind of those 4 steps. Another big piece of the whole surrogacy process is the insurance piece. And really, when we talk about insurance, we're kind of looking at 2 things, but there are a couple other issues I'll mention. So first is obviously what's called dependent coverage, which is just the coverage for your baby or babies to be born. And despite the fact that everyone, potentially, obviously, domestic parents will have their own health insurance in this country, and international may have some global, you still have to look at those plans to make sure you're going to be fully protected when that baby's born. Because even if you're living in Massachusetts and you think you have great insurance plan, that insurance may not cover a child born in North Carolina because it's a PPO rather than an HMO, or it has only emergency coverage outside the state. So you want to investigate your insurance piece to make sure you do have protections and coverage. Second to that, in your own insurance, is you want to look at how it details IVF cover. You may have the ability to get some coverage for your IVF process, whether it's just your blood analysis, semen analysis, your fertility testing, potentially the creation of your embryos may be covered by your insurance. And also it's worth looking into your company's benefits too, because some companies now, or actually a lot of companies now, are offering surrogacy and IVF benefits outside of their medical coverage. And they've teamed up with companies like Carrot or Progeny, which are third-party insurance companies that offers just specific fertility-based insurance. And if you're with an employer of 500 more employees, it's something you may want to talk to your HR about looking into, of maybe getting on a Progeny plan or finding out if Carrot can work with your employer. So these are ways to kind of defer some of those costs. Maternity cover, obviously, is the other big issue. You want to make sure your surrogate has adequate insurance for this process. Some states now, the new New York statute requires a full 2 years of insurance coverage for your surrogate. But I'd say for the most part, surrogates come to us one of 2 ways. They either have insurance in place that should cover the surrogate pregnancy, or they have insurance in place that has a specific exclusion for surrogacy. And in those cases, you're either finding a third-party plan to cover, or potentially another health insurance plan that may cover surrogacy. But we're going to help you with that process. The way we've created our system, you're paying one set fee for insurance and medical related costs. So regardless of what the insurance situation is, you don't have to worry. Circle's going to kind of take on that extra risk and work through the insurance language and buy extra cover if needed, et cetera. The smaller pieces of insurance involved, we always have a life insurance plan in place for our surrogates. So you'd purchase an accidental life policy, death policy in case something were to happen to her during the pregnancy, to protect her and her family, as well as potentially your case as well. And then we have what's called IVF, or IVF complications insurance for both egg donors and surrogates in case they have any complications from the IVF process. Finally, from an insurance piece, the other aspect is Circle offers fixed programs. We have a fixed fee and a journey guarantee program, which offer our own self-insurance aspect. So from a fixed program standpoint, what it is you pay kind of one set fee to get through an embryo transfer and then of entire pregnancy. If there is a miscarriage or a transfer doesn't work, you pay a small set fee to get to another transfer through a pregnancy. And then our Journey Protection Guarantee program is basically you pay one set fee up front. It gives you up to 5 embryo transfers. If you don't have a live child at the end of that, you get your agency fee back plus whatever potential third-party expenses are there. So we've built in our own insurance product into it. Which was this slide, which I should have gone to. But anyway, those are our two major programs we have, this fixed cost and this journey protection program. Finally, the last part I wanted to talk about was our financing plan for surrogacy and egg donation. So we've teamed up with Origin Finance, which is exclusive to Circle Surrogacy and Egg Donation. And basically, it is a third-party lender that allows intended parents to borrow up to $65,000 of the cost of their journey with terms of about either 3 or 6 years. And I believe interest rates somewhere in the 6 to 7 range. I think obviously it fluctuates, but it's a lower end. So obviously it's like any other loan, you'd apply for it during the process. It's funded at the time of match with your surrogate, so you'd pay any upfront costs, and then that 65,000 or whatever number you apply for and receive would be funded when you match with the surrogate. It would be funded directly to your escrow account, so you don't have to worry about getting it and then putting it over. It'll go right into the escrow. Qualifications, it's only applicable to US citizens at the moment. You need to reside in one of the eligible states, which are all below, which are Colorado, Connecticut, Florida, Georgia, Illinois, Massachusetts, New Jersey, New York, North Carolina, Ohio, Pennsylvania, Texas, Virginia, and Washington, D.C. California is soon to come after that. And again, there'll be criteria you have to meet, but those will be defined by the financier. So that is the end for kind of that legal overview, insurance and costs. I'll turn it over to Nancy, who will talk now more on the process side. So Nancy, can you hear me?
I can. Thank you, Dean. And thank you, everyone, for joining us this evening. We're really happy to have you join us. As Dean said, I am Nancy Weatherby. I am the IP Outreach Manager for the agency. I, too, have been with the agency. I'm on my 16th year. Just crazy how time flies. I'm very fortunate to do what I do. And the reason why I do what I do is my husband and I do have 2 children through the surrogacy process. So I've got some personal experience going through surrogacy and just absolutely enjoy sharing what I've learned and my personal experience with everyone as they start through their process. So I think the first step we'll do, I'll just walk you through a general timeline of what it would look like if you do decide to work with us. Now, of course, before making the decision to work with us, we would want you to meet with us for a private consultation. They usually run around 2 hours long, and we have you speak with someone like myself who will review the process in detail with you. And then the second part of the consultation will be with one of our attorneys. We try and split our time equally, but it's very important to make sure you're speaking with an attorney to understand all the legal and insurance aspects, and of course the financial packages that go along with the program at time of consultation. So if after the consultation you decide you do want to join on board with us, we hope you will. The first step we will do is, of course, welcome you to the agency. We'd like to assign you a program coordination team. We like the team approach. It'll consist of a program coordinator and a program manager, so that either or if any of those members happen to be out of the office, the other is there to step in. We will also assign an attorney to your case, as well as an accountant. And really it'll be that team that will be guiding you through. So you have a small team guiding you through the process from start to finish. At the time of joining, you will also be creating your matching profile. And a lot of this, most of these steps will be handled for you and with you by your program coordination team. They're really with you from start to finish. They'll help you create your profile. They'll help you confirm the IVF clinic you want to work with. Many intended parents come to us already working with an IVF clinic, but if you don't have a clinic when you come to us, we're also happy to provide a recommendation and a referral to someone like ORM who's on the call this evening. And we can help you choose your IVF clinic. We will help you choose and match with an egg donor and sort of start the IVF process. So once you have your clinic, your donor in place while you're waiting for your carrier match, you can actually move forward with the process of creating embryos. It's encouraged. That's how we encourage everyone to move forward, so that when you are matched with your gestational carrier, we do have a wait time to match you with a fully screened carrier. You'll be ready to go. You'll have your frozen embryos in place. You'll be ready to then match with your carrier, take care of the carrier contract, which of course our attorneys, someone from Dean's team, will handle for you. We represent the intended parents all the way through the process. And once that match is in place, you've got your carrier now, your frozen embryos, you can move forward with the IVF process. And the frozen embryo transfers looking to hopefully get you to the next stage as smoothly and as quickly as possible, and that is to the pregnancy stage. I'm going to back up a little bit. I did say that we have a wait time to match you with the screened carrier. I'll talk about that a little bit more in just a second. But we do all of our agency screening on our carriers first. We do work with gestational carriers from all over the United States, except for those 3 states that Dean mentioned earlier. And we do that to make sure we get the biggest pool of women from which to screen from. In the end, we're really only accepting 1 to 2% of the women that are applying. We are typically quoting 3 to 5 months, and it's a 3 to 5 month wait time to match with the gestational carrier if you're looking to do a single embryo transfer. If you are looking to potentially transfer 2 embryos for our domestic clients, or if you have very specific matching needs based on your situation, your personal situation, it could be a little bit longer than that. It is still a little early for us to say what kind of impact we're going to see from COVID. We still have carriers applying over the last month, just at a heavily reduced rate, but we still have carriers applying. We still have parents joining. We are still moving forward with all of our screening and matching process for everybody. So there could potentially be a delay. I don't know exactly yet what that's going to look like. I'm hoping it won't be too much of an impact. For people that are joining now, certainly, or in the near future, there shouldn't be too much of an impact because, like I said, you do have that wait time to match with the carrier anyway. And so you'll be moving up that match board. Once we move you on to the next stage of being pregnant, we all jump for joy once that is confirmed, and that is confirmed by confirmation of heartbeat through ultrasound. So it's not just the first initial blood work, it is at the point of there's an ultrasound that confirms a heartbeat. We all jump with joy and excitement, and officially announce that you're pregnant. The coordination piece will drop a little bit. It's only natural at this point. You are pregnant. We do need you in the pregnancy to sort of move forward. We do strongly encourage relationships. We actually require relationships between our intended parents and our carriers. And so during this time, we're asking that you're still, closely contacting your carrier weekly. Some intended parents will actually do so daily. But it's important to just keep that nice, friendly, open relationship with your carrier as the process moves forward. Of course, your coordinator is always there. Your team is always there to support you throughout the entire process. And as you approach delivery, I believe it's at around 28 to 30 weeks of pregnancy, you will see the coordinator jump back in so that she can make sure that things like the birth plan is being worked on. We want to make sure you and your carrier are working on what that birth plan will look like. She will also, the coordinator will also contact the local hospital where delivery will take place to make sure that they're aware that it's a gestational surrogacy delivery, that they know who the local attorney is, who we will locate for you that will be helping you with your parental rights. We always find an attorney on the ground because, like I said before, the carriers can live anywhere in the United States. And there's all types of other little tidbits of things that sort of happen at this stage as well. We have an intended parent handbook that tells you what each step is going to look like and what you can expect. And we also have these, helpful part of the document as you approach delivery, things you need to be thinking about will help you locate hotel accommodations, short-term apartment if that's needed for some of our international clients. Make sure that you've thought about where you're going to buy your car seat, what you're going to need before you can leave the hospital and things like that. We also will, of course, support everyone throughout the process, all the way through delivery and for several months after. We'll help you craft what that relationship will look like with your carrier after delivery and at time of delivery. We do ask, that intended parents give the carriers the opportunity to see the baby, hold the baby, let their families do the same, just to provide some closure. When a carrier makes a decision to go through this process and help intended parents, they're really looking to do this to help, but really it's a family decision. The, her support partner, her husband, her children, they're all in it with her. And so we do ask that you provide some closure and let them see and hold and see how happy they've made the new family. And then of course we'll provide support, like I said, for several months post-delivery as well. There's going to be all types of medical bills, co-payments that we'll take care of for you. As Dean said earlier, we really are full service. We have our own attorneys, our own social work team. We have our own in-house accounting that will take care of all of your payments through your escrow account. And we even recently created our own medical billing team that helps with local monitoring and also processing of all the medical bills, so that you don't have to worry about any of that. We really want you to be able to focus on the enjoyment of the process and creating that connection with your carrier and your egg donor if you want to as well. So it's sort of what the timeline looks like. Average, 15 to 20 months. Again, it really does vary based on individual circumstances, but that's an average. So again, this slide here talks a little bit about what we provide for support. We understand, I always tell people, I've done this on my own. I can tell you from the years of experience of working with Circle and doing it myself, it is a very successful process. I never lie and say it's easy. It is a very complex process, and so we want to make sure that we're there for everyone every step of the way and that we provide support to everyone involved. Again, the team approach, I mentioned this earlier, your program coordination team is going to help coordinate and support all parties. So everyone, they'll represent you and speaking with the surrogate, the donor, and setting up insurance within Circle and outside of Circle. We have some sort of third-party insurance as well. They will coordinate with your clinic for the screening of your donor, your carrier, your own screening, and of course prepare for the hospital and coordinate for all third parties, including travel. All of the travel arrangements for donors and carriers are coordinated through your PC team as well. They will make sure that your escrow account is taken care of. Any questions, concerns, are always working closely with accounting. If you have any questions or concerns about your escrow or your accounting, you can speak directly with your program coordinator or the accountant that will be assigned to your case as you move forward. I feel like I've already gone through a lot of the information already on this slide. But the goal of this is the amount of support that we're providing for everyone as you move through this process. So a little bit about the egg donors. Now, not everyone comes to us needing an egg donor, but for those of you that do, we do have our own database. We usually average about 300 to 350 donors in our database on average, and that we do also have partnerships in place with other egg donor agencies, so that if you can't find that perfect donor in our database, we have partnerships in place and we can make that connection for you through us, and we will help do that for you if needed with other donor agencies. So it brings your pool of available donor profiles usually to around 1,000, sometimes a little bit more than that, depending on what the other databases look like at that time. The general requirement, most egg donors are young college students. We usually will see, I know we have here the age of 21 to 29. I think most of them fall right in the middle there. They do need to be a US or Canadian citizen. We do ask them for full family history, both sides of their family. So we're of course looking for a healthy family history. We do want to make sure that they are not, abusing alcohol, smoking cigarettes, doing any type of illegal drugs. They will be screened for that as well at the fertility clinic. And as I said, most of the donors that we're seeing come into the program are college students that are going through this process. There are 3 types of relationships that you can choose with your donor that I want to touch on real quick. Sorry, Dean. I'll do this quickly, but I just want to make sure everyone knows that Circle's pretty unique and that we offer 3 different levels of relationship with your egg donor. You can choose an anonymous donation where you simply are choosing someone from our database where you see her photos and her profile. Then the next step over that would be what we call a semi-known relationship. And in that, you can choose to have a phone call or a Zoom video call with your donor so that you can learn a little bit more about her personality and ask some more questions if you want. In the semi-known, we don't actually release any identifying information, so no last names, no email addresses or anything like that. The third option is a full known donation. The majority of our intended parents now are actually choosing this, and it's the full known. And in that case, you would actually speak to the donor, and if you do decide to work with her, you would agree to exchange contact information with your donor. Whatever level of relationship you're comfortable with is what we can craft. Some people speak to their donor and remain friends and speak every few months, and others may speak to their donor once a year with an update. So it is whatever you're comfortable with. There are a lot of benefits to having a known relationship. Certainly for if the child is interested in meeting the donor later in life, and for medical purposes as well. And we go into all those details during the consultation. I won't go into all the details here this evening for you. So the next, the next slide talks a little bit about our surrogates and what they look like. And I promise you that the carriers that we screen into the program, that we are fortunate enough to work with, are women who genuinely want to help a family have a child. If during the screening process we have the sense or we get the sense that they're maybe more financially motivated than they are any other reason, we won't work with them. We're not that agency. We feel very strongly about everybody having an open, honest relationship with each other, and you can't do that with a carrier who's doing this purely for the financial reasons and not in it for the good of it. And I will tell you, the women are amazing. They oftentimes will come to us during the initial application stage, and we hear time and time again that they love being pregnant. They've either sometimes watched a friend or family member struggle with infertility, and it's something they enjoy, and they know that they and really want to help intended parents have a child of their own. It's a huge sense of accomplishment that they get through this process, and we're very thankful for them. I mean, it's just, so many miracles. Like Dean said, over 2,100 babies born, and it wouldn't be for the selflessness of the women that are stepping forward to act as gestational carriers. So basic across the board, more or less industry standard, if you will, guidelines for being a gestational carrier is a healthy BMI. Every fertility clinic sort of has their own guidelines. We always know what they are. We always make sure we know the clinic that you're working with, what their guidelines are. We coordinate with them. One of those is a healthy BMI, generally between the ages of 21 and 41. It's an absolute requirement that in order to act as a carrier, you have given birth to a healthy child, a healthy normal pregnancy in the past without complications. They do need to pass a psychological screen with our team. They will be medically approved by the fertility clinic that you're working with, but we actually take the extra step of getting all of their past OB records sent into us. We put them together. We have a nurse on the team that will put all the records together, and we will actually send their past pregnancy records to the fertility clinic that you're going to be working with for them to take a look at the medical records, approve the medical records, and sort of, give the green light that everything from a paperwork point of view looks good before we present you with a profile. We recognize that this adds a little bit of time to our screening and matching process, and that's why we do have a little bit of a wait, as I mentioned earlier. But we think it's a really important part of the process. So it's something that we do take the time to do. I don't think most agencies do this. We feel strongly about taking the time to do that. They have to, of course, live in a surrogate-friendly state. It is very important, I think I touched on this earlier, that this isn't something just the gestational carrier is willing to do. This is something that we need to make sure her family supports her doing, because they will ultimately be in this journey with the carrier. It is a long process, you know, the good 15 to 20 months as they go throughout the journey, it will be their family supporting them. And so we, in addition to interviewing the gestational carrier, we always set up, our social work team will set up a separate interview with her husband if she's married. And if not, we do ask her to identify a support person, and we do speak to that support person as well to make sure that she has a lot of support around her before she moves forward with the process. And then, of course, we want to make sure they're not, you know, using illegal drugs, smoking cigarettes, or abusing alcohol. And again, once you are presented a profile of a screened carrier and you do decide to work with her and you move forward, she will then go to your fertility clinic for a full medical screening, which will include screening for the use of illegal drugs and smoking cigarettes. So that's a little bit about our surrogates. What I will do now is turn you over to the ORM physicians so they can talk a little bit more in detail about the IVF and the medical piece of the process.
Thanks, Nancy.
Yep.
So I'm going to introduce again both Dr. Bankowski and Dr. Massie. So can you hear me?
You sure can.
Yes. Yes. Can you hear us, Dean?
Yep. So just let me know if I need to click through a slide. I'll be listening the whole time. All right.
Great. Perfect. Okay. Well, first of all, thank you so much to Dean and Nancy and the entire team at Circle for helping us to arrange this call. Thanks to all of you at home as well for just taking some of your time during this sort of unique and challenging time that we have to learn about surrogacy. So we hope that it helps. We won't take up too much of your evening, but next slide, Dean. I'd just like to introduce our talk. First of all, Dr. Massie and I will just give you brief introductions to our backgrounds. And then we'll touch on what's important medically in the donor screening process and kind of key takeaways that we've learned after doing a couple thousand surrogacies. We'll go over the surrogate screening process, which is a little bit of a simpler process because the genetics aren't as important, and talk about takeaways there. And then give you a brief overview of what donor egg treatment would be if you're not in need of an egg donor. Certainly the IVF part of this would apply either way. And then we'll talk about, briefly touch on fresh versus frozen eggs and embryos, and talk about pre-implantation genetic testing. And then lastly, just talk about the surrogate screening process and explain a little bit of ORM's experience and our success rates. So first of all, just to introduce our clinic, Oregon Reproductive Medicine was founded originally in 1989. In our most current form, it really started in 1999 when Dr. Hessla left CCRM and joined my partner, who's now retired, Dr. Materi. We've now grown to be 7 physicians in 2 locations doing, according to the 2018 SART data, the success rate data that just came out over 2,000 cycles. A big key to our success is actually the investment that we've put into our embryo clean room, which in embryology laboratory is a very precisely controlled environment to allow us to grow embryos in the best possible way. And the thing that has furthered our ability to help our patients is our investment in our in-house genomics team. Reproductive genomics is kind of a unique part of genetic medicine, but it really is a key to helping us achieve our main goal for you, which is to maximize the success that you have in having a genetically healthy baby on your first transfer. Just the most boring part of the talk. Just quickly, my background, I studied biomechanical engineering at Cornell and did medical school in Washington, D.C. I spent 7 years at the Johns Hopkins Hospital, which was basically fertility school, internship residency, my fellowship. During my fellowship, I also got a master's degree in public health, which I've been sort of dredging up all that old information about studying pandemics and everything as they apply to what we do now. I didn't necessarily set out to become an expert in surrogacy. It has become about half of my practice. And recently I did my 1000th surrogacy transfer. And so part of my goal here is just to share with you what I've learned over that time period. But I'd like Dr. Massie to introduce herself and kind of kick off the talk about the basics of our screening of donors then.
Thank you, Dr. Bankowski, and thank you to everybody for joining us tonight and letting me be here. Agree with Dr. Bankowski that this is kind of a boring part of the talk, but just so you know a little bit about me. I went to the University of Maryland, College Park for undergrad, where I studied physiology and neurobiology, and then I stayed there for medical school in Baltimore. And then I actually did my internship, residency, and fellowship all at Stanford. Fun fact about me is that I was an active duty military member. I actually went to medical school on a military scholarship. So after I graduated from my fellowship at Stanford, I paid back my military time as an infertility specialist in the military and had the great joy of joining the ORN team after I completed my payback to the military just last May. So you can go ahead and go to the next slide. So we're going to start just by talking about the egg donor. There's a very extensive screening and evaluation process that egg donors go through before they're actually approved to do an egg collection cycle. And the screening generally has 3 components. So it has a medical piece, it has a genetic piece, and then it has a psychologic screening component. We'll kind of talk about each one of those. So from a medical evaluation standpoint, all donors undergo a general medical exam and then infectious disease screening. So this is testing for things like HIV, hepatitis B, hepatitis C, and syphilis. All of the infectious disease screening that egg donors go through in the United States is actually governed by the Food and Drug Administration, or the FDA. So which testing and the timing of that testing is all driven by the FDA. Potential donors then undergo a very specific type of testing that's geared toward checking their fertility or their egg supply, which is obviously a critical component of being a successful donor. And we do that in 2 ways. We do both hormonal assessment and ultrasound evaluations to check the potential donor's egg supply and make sure that we think that her ovaries are healthy and robust in order to allow for a good number of eggs collected in a successful cycle. The next component is the genetic component, and this piece is really quite widely variable from agency to agency and clinic to clinic. At ORM, we have a very extensive genetic screening process that our donors go through. So it starts with something called expanded genetic carrier screening. This is a type of a blood test that's designed to look for genetic mutations that can, in certain circumstances, cause genetic disease in infants and in babies. The next pieces are an extensive family history questionnaire that the potential donor fills out, and then a genetic consultation, one-on-one with our genetic counselors. And during that consultation, the genetic counselor actually goes back 3 generations of family history with that donor to make sure that there's no evidence that this donor's eggs could potentially be in a situation to result in a genetic illness in the infant. The final component is the psychologic screen, and it kind of fulfills a 2-fold purpose. The first is that we want to make sure that the donor has the cognitive skill and emotional stability to actually get through the gestation or through the donor egg process successfully. And the second piece is that we want to evaluate and see if there's any evidence that there could be conditions such as mental illness or learning disabilities that could be present in that donor. It's only after an egg donor completely successfully goes through each one of these components that she's then approved to be an egg donor and can be matched with an intended parent.
So I'd just like to share a little bit of kind of what I've seen after talking with many intended parents over the years. it's natural that patients or future intended parents are looking at programs and saying, oh my gosh, look, they've got hundreds and hundreds of donors. Like, oh, look at the donors, look at how pretty they are, look how tall they are. In certain circumstances, based on whatever ethnicity you might be, you might have an interest in a donor of a certain ethnicity, which is completely fine. It just may limit your search criteria to a narrower pool, and therefore you sort of have to cast a larger net. I often hear that the patients are interested in donors that have higher education beyond that of college. And that's fine. However, you have to understand that, you know, it takes about 6 or 7 years to get a PhD. That starts after college, which is 22. And most programs use donors that are only in their 20s because women are born with all the eggs that they ever have. And as they get older, the number of eggs that they have decreases, and the percent of embryos that are genetically normal decreases as well. So it may not be possible. And as Nancy said, a lot of the donors we see are actually in college and not yet have completed their degrees. There's also a great interest in proven donors, which I completely understand the reasoning. However, that is, if you just limit yourself to proven donors, you are going to look at a much smaller pool. All proven donors were first-time donors, and of course, because we screen so thoroughly, it is not necessarily guaranteed that the donor in her subsequent cycle is going to do how she did in the cycle before that. So that's an important thing to understand. From the ORM perspective, what we're looking at really isn't that there's 300 or 500 or 1,000 or however many donors, because you're going to fall in love with one of them. So when we think of this, we look at all the criteria of that particular donor, from their reproductive health, their genetic health, everything that we can see. And so we're looking at the quality of the donor characteristics. Interesting to know that as we look, for example, with our own donor pool, the very first test that we do is the genetic counselor's full family pedigree. Because it rejects 40% of candidates if you sit down with them and talk for them with an hour about anything that might exist in their family. That is really, really important. Donor egg is all about genetic health. We have seen publications and see a lot of donors from a lot of places, and typically see donors that have a range of about 18 to 20 or so eggs collected, which is fine in many cases. When we're looking at donors, especially for a couple in which there's going to be potentially 2 sperm providers, we would recommend more than that. Our donors, for example, have over 30 eggs collected on average. And if you think about a pyramid and turn it upside down, 30 eggs collected, we see on average 22 of those in total that are mature. When you add in the sperm, if those 22 are split, let's say between 2 sperm providers, you add in the sperm, about 3 out of 4 of those mature eggs successfully fertilized. So from 30 eggs, now you're down to 16 embryos that are single cell embryos on day 1. And if you grow those to day 5, which is the stage that's ready to implant or to be tested, only about 8 or 9 of them generally grow. And if you do genetic testing, depending on what type you're doing, about 5 to 6 are typically euploid, which means chromosomally normal or genetically normal. And so that's really important as well. And then the other thing, just from our standpoint, is when we see donors from all over the place, it means that we have to rely on a lot of people doing a lot of different ultrasounds and blood tests. And we've actually changed the way we do screening so that our donors come from a geographic location which is close to an ORM facility, so that's one of the ways that we can kind of control the quality of the information that we get, simply because when you're working with donors from all over the place, it is kind of tricky to make sure that we're getting the information that we need to make sure that your cycle is going to go well. So next slide. Yeah, thanks. This is just an example of our genomic team, and you can see that just based on the initial screening, over half of the donors we see are denied right off the bat by our genomics team. And some of what they pick up is actually a little bit more subtle than you might think. It's not necessarily that they have genetic disease in their family. It may be that they have two members of their family that were alcoholics, maybe an uncle on one side and their grandfather on another. That alone would put your child at an increased risk of being an alcoholic. And we know that our patients don't want to take that risk. And so the other key point to realize with this is just that everyone has something in their family. And really, it's important to rely on the body of literature for reproductive genomics to understand not what exactly that is, but what that means for you, your children. And so what we would produce is a genetic information and family tree, or the GIFT, which is an analysis of what that donor said is in their family, what it is, what it means, and then does it have any risk for you, so that every one of our donors, whether it's within our program or outside, before you would go through the process, would have that.
Okay, on to gestational carrier evaluation. So just like our egg donors, gestational carriers also go through a very extensive evaluation before they're approved to carry a baby for an intended parent. This generally starts with a health history, which Nancy touched on, which is a medical record review. And essentially what your physician is doing in that medical record review is looking at all of the pertinent history that's been documented on that gestational carrier. So that's things like their obstetrical history. How many pregnancies have they had? How many babies have they delivered? Did they have any complications during the pregnancy or during the delivery? Were there any issues that arose that could potentially cause concern? Looking at their GYN history to make sure there's no disorders or conditions that might decrease the chance that an embryo would successfully implant and grow. And then obviously we're looking at the health of the gestational carrier. We want to make sure that they don't have any conditions such as uncontrolled hypertension or diabetes, things that could potentially cause an increased risk both to the carrier herself and potentially to the baby. In terms of the psychological evaluation, so similar components to the evaluation done by the egg donor. In the same vein, we want to make sure that the gestational carrier understands exactly what the process looks like, that they feel emotionally stable and ready to successfully complete their gestational carrier journey. But in addition, we always want to make sure as well that the gestational carrier is in a position to offer a safe environment in which to grow the baby, both from a physical and from an environmental standpoint. The carrier will also complete a comprehensive medical exam. So this includes things like infectious disease testing, HIV, hepatitis B, hepatitis C, etc. Prenatal labs. So we want to make sure that the carrier is immune to what she's supposed to be immune to, that her blood count is good, that we know her blood type, and that she's completed all of the routine or recommended screening tests such as pap smears and mammograms, etc. And then the final component of the evaluation is really a very focused examination to look at the uterine cavity itself, so the uterus itself. And we generally do this with a test called an SIS, or a saline infusion sonohystogram. This is an ultrasound-based study where we put a little fluid into the uterus. We make sure there's nothing poking into the uterine cavity that could decrease the chance that an embryo would implant and grow. That's things like fibroids, which are little overgrowths of muscle, or polyps, which are little overgrowths of lining. And then your physician may recommend that your gestational carrier undergo what's called a mock cycle. So this is just a cycle where we prepare the uterus for a transfer, just like we will when we do the real thing, except for we don't transfer an embryo at the end. And sometimes this is recommended just to make sure that the lining develops as we would expect it to, and that there are no unforeseen issues when we're actually moving forward to do the transfer itself.
And mock cycles were actually a lot more common back when we did fresh transfers. I can't remember the last fresh transfer that we've done here into a surrogate. And the main reason for that is because of the increasing success of cryopreservation of embryos and the fact that almost all of our patients choose to electively do genetic testing on the embryos, which requires that they are cryopreserved or they're frozen. So if you have a cycle in which a surrogate does not develop an adequate lining, then you just keep the embryos frozen and you don't thaw them. So we don't really need to do mock cycles, which is great because it saves time, it saves the surrogates having to go through those medicines twice, and we don't have to purchase the medicine, so it's less expensive. It's just a more efficient approach. So a little bit about, again, patient versus doctor perspectives. So patients naturally, when they're shown a profile, whether it's on an electronic PDF or it's a page, or actually it's a video call, they're attracted to the personality. This is really important because, as Nancy said, having a relationship with the surrogate is an incredibly important part of the process, and that allows you to communicate. If you feel like you have trouble communicating with the surrogate based on the first introductory call, that is not a great choice for you, and so you should work with your team at Circle to talk through that and figure out a plan. Age isn't really a huge factor. One way to think about this is that the uterus is a muscle, kind of like your bicep. Whether you're 30 or 35 or 40, that your bicep is going to work fine. And so we actually see that women do really well. Most clinics will have a certain age range of surrogates that they're expecting, but within that age range, we don't see any difference in outcomes. Location, assuming that it's from a legally safe state, a location really is more important, I think, to you. Do you want the surrogate to be close to you? Do you want them to be in a place where it's easy to get to, where you have family? All surrogates will fly to most fertility clinics, I think, for a testing visit and then for the transfer. So we see all of our surrogates twice so that we can teach them and counsel them and test them ourselves and make sure that the transfer is going to go well. And then obviously you have to rely on a trusted agency like Circle. This is really important now because at one of the recent meetings, somebody told me there's 400 surrogacy agencies now in the United States, which means there's been a big explosion of about 200 new ones. And a lot of the new ones don't necessarily have the experience to know what is an appropriate socially or medically screened surrogate. From our standpoint, we're interested, of course, in the medical records and reviewing them prior to the match. We want you to know, as Nancy said, that your surrogate has the ORM stamp of approval, and that the next thing that we're going to be involved in is actually testing the uterus. I have only rejected 3 or 4 surrogates in my whole career at the actual uterine testing. And they're for really dramatic things. One had a tumor, a very large tumor in the uterus that she didn't know about, things like that. We're, of course, interested in the medical and the obstetric issues, meaning did they have any problems during the pregnancy? Things in the delivery aren't quite as important as things that may have come up during the pregnancy, but we factor all of those in when we look at our surrogates. One thing to note is that we've had trouble for years with surrogates who are coming off of long-term hormonal use. For example, they have IUDs, intrauterine devices that are impregnated with progesterone, and it slowly gives off that progesterone. There are also different forms of this you can put in your arm, but these things really suppress the uterine lining for many, many months. And one of the things that we're seeing is that an OBGYN understands that a woman wants to be a surrogate, so they'll remove these, but then they'll put them on birth control pills to regulate their cycle right away, which is continued suppression. And so the lining it doesn't have enough receptors in it when it's been suppressed so long. So we really need a really good amount of time, at least 3 months, sometimes up to 6 months, for that surrogate to come out from under that suppression and be able to respond to the medicines we're going to use. The expert intrauterine testing is just because we've been burned in a lot of places, people telling us that the uterus is perfect for this embryo, and it's not. You really need really clear imaging, or the best possible saline sonogram, or even hysteroscopy to make sure that the internal anatomy is normal. Commitment to and compliance with the ORM medical process. This is not negotiable. We all have the same goal, and that is for the surrogate to have the best possible chance of success. And then triangulation. This is natural that the surrogate doesn't want to make any mistakes. They don't want to look bad in front of you. They want to do their very best, but it's a complicated process. And so the more communication, the better. And we don't want a surrogate saying that, oh, ORM or any clinic said to do this and that. We want all of us to be on the same page. Again, there's no reason why it should be a he said, she said. The cycles that go the best are the ones that have the most transparent and open communication.
All right, let's talk about the process. So once you've selected an egg donor and they've completed the pre-cycle testing and all of the screening process, they can then move forward with the egg collection procedure itself. And from the time we start stimulation medications until we have embryos created is a process that takes about 2 weeks. So it's really the lead up to this point that is the time intensive process. And then once we start this, things tend to go quite smoothly. We always start with the ovaries in what we call a resting state. We generally achieve that by having the donor on some sort of hormonal suppression, like a birth control pill leading into the cycle. This is just usually just a short duration of pills to get the ovary quiet so we can start the stimulation. The donor then starts injectable forms of 2 hormones, FSH and LH. FSH is kind of like egg food, and it's the exact same hormone that your brain makes in a natural cycle to support the development and growth of an egg. The difference with IVF is that when our body naturally makes this hormone, we only make enough really to support the growth of 1 egg. By injecting these medications, these hormones, we actually can give the body enough egg food to support the development of many eggs at the same time. And we monitor that development with a blood work and ultrasound. Although we can't see the eggs on ultrasound, they're microscopic. As they grow and develop, they create these fluid collections around them called follicles. And that's what you're seeing in that second image. So the ovary goes from a wet resting state to a stimulated state, and all of those little fluid collections within the ovary are hopefully surrounding eggs that are maturing. Once those follicles get to a certain size, then it's likely that they're going to contain an egg that's mature, and the donor will then do what's called a trigger shot, which is just a hormonal injection that times the release of the egg. She will then undergo an egg collection procedure. This is an outpatient procedure. It's done transvaginally, so there's no scars, nothing to see on the outside. We use a needle that's a little bigger than the one that's used to draw blood. It goes through the wall of the vagina and into the ovaries and collects the fluid that contains the eggs. The procedure takes about 15 to 20 minutes, start to finish. Once the embryologists have the eggs in the laboratory, they then fertilize them. And there's generally 2 ways we can fertilize eggs. We can use what's called standard insemination, which is where we just put the eggs together in the dish with the sperm and allow them to fertilize naturally. Or we use a process called ICSI, which is where we inject a single sperm into each mature egg. The vast majority of our patients using egg donors use ICSI because patients who use ICSI generally get a higher fertilization rate. And when we're doing an egg donor cycle, then even an additional embryo is obviously a huge win and worthwhile. So I would say the vast majority of our patients fertilize their eggs using ICSI. Those fertilized eggs then grow in the lab, as Dr. Bankowski mentioned, for 5 to 6 days. And at that point, they've reached the stage of a development called the blastocyst. And you can see that in the final image. At this point, they've developed into 2 distinct cell lines. You have that little kind of nub of cells on the left called an inner cell mass. That's the part that becomes the baby. And then that ring of cells around the outside called the trophectoderm, and that's what becomes the placenta. It's at this stage that the embryo can either be transferred fresh into the uterus or can be frozen and undergo genetic testing. We can go on to the next.
Yeah, so we're commonly asked about fresh versus frozen eggs. The bottom line is that we almost never use frozen eggs in our practice. There really only are 2 theoretical advantages. One is that because those eggs are already frozen, it saves you 3 or 4 weeks of time. But as you saw Nancy's timeline, this process unfolds over 18 to 20 months in many times. So that offers really no advantage because you can use the time while you're waiting for your surrogate to actually choose the donor that you want and put her through the process. The other thing is that it is potentially lower cost. The way that it's lower cost is that programs that would do this would pay a donor one time, but then they would split the batch of eggs that they have into smaller batches that they would offer 6 or 7 or 8 or whatever it is. And they would offer those at a discounted rate. But as I told you, if you start with 30 fresh eggs, at the end of the day, you have about 5 or 6 normal embryos. And so just starting with 6 frozen eggs, it's usually not nearly the chances that you can get of having a genetically healthy embryo to transfer, certainly not for 2 intended parents, unless you were to buy multiple batches of eggs that were frozen, and then there's no cost savings. If you were to boil down all of the the studies done on success rates, it looks like it's about a third less successful as well, which it's not about the rate of success, it's about the cost effectiveness of the whole process. And frozen eggs are very, very rarely used. Next slide. Another thing to understand too is that we almost, at least in our practice, almost always do pre-implantation genetic testing. The reason why this is offered electively but is almost always chosen is that the fact is that over a third of the embryos that we see being tested from an egg donor, and this is a woman who, again, is at the peak of her fertility and has passed all of our screening. We only accept about 5% of egg donors that apply. About 30 to 40% of those embryos are actually genetically abnormal. And this just tells you that the process by which the DNA of a sperm and an egg merge together, which is called fertilization, is really incredibly complicated. And embryos that do not have the correct number of chromosomes, that don't have 46 chromosomes, they generally either end up as negative cycles or early miscarriages. And so this pre-implantation genetic testing, which has become incredibly advanced now with next generation sequencing and SNP array technology, is a big part, but it's a much longer discussion that you should have with your clinic and your genetic counselors.
Once you have created embryos, the gestational carrier portion, so getting the uterus ready for transfer, as Dr. Bankowski mentioned earlier, is actually quite straightforward. So there's two ways that we prepare the uterus for an embryo transfer. One is with what's called the natural cycle. So that means just watching the gestational carrier go through her own menstrual cycle and timing the transfer of the embryo based on those parameters. As Dr. Bankowski mentioned, that is very unusual now. The grand majority, the vast majority of our gestational carriers do program cycles with frozen embryo transfers. So a program cycle or medicated frozen embryo transfer is where we use supplemental forms of estrogen and progesterone to get the lining ready. And what we're really looking for is that that lining gets to be nice and thick and fluffy and has this beautiful pattern called the trilaminar pattern. You can see in that picture those kind of three bright lines that tell us that the lining is ready for implantation to occur. Once that happens, the embryo transfer procedure is performed, and this is a procedure that takes about 10 to 20 minutes. The gestational carrier is awake during the procedure. We use an embryo transfer catheter that's kind of like a hollowed out spaghetti noodle. The embryologist loads the embryo into the transfer catheter, and then we place that catheter into the top of the uterus called the uterine fundus, deposit the embryo there, and then withdraw the catheter. All of that is done under ultrasound guidance, so we can see exactly where that catheter tip is being placed. And then a short 9 days later, your gestational carrier will come in for a blood pregnancy test, and at that point we know that the embryo found a place to implant and grow and that a pregnancy has been established.
And then just a little bit about our experience. So actually, I would have made some changes if I looked at this one more time. Let me tell you two things about this slide. Number one, look at the right chart first, because this is what you'll be able to see on the SART database, the Society of Assisted Reproductive Technology. SART does not separate out 1 versus 2 embryo transfers easily, and if you apply all the filters, you can tell things a little bit better, but basically it'll show you that the average surrogacy live birth rate is 61%, and at ORMs it's 77%. But what we actually present to our patients is, number one, not just 1 year, because anybody can have a good year. We present the last 5 years of data, and we break it up into those who have transferred a single embryo and those who have transferred 2. And this is what the patients decide to do. Now, interestingly, historically, over the last 5 years, it's changed quite a lot. We used to do about half double embryo transfers, and now it's probably about 1 out of 4 patients. A lot of that just has to do with, I think, number one, awareness, number two, about the ability of intended parents to find a surrogate who will accept a double embryo transfer. Each embryo has about a 2 out of 3 chance to make a baby, and any embryo we transfer can split. So if you see this data, this is somewhere between 900 and 1,000 transfers. I should have put the actual sample size on it, but it's over 900 transfers. A single embryo transfers had a 69% live birth rate with 1% twins. In the couples that chose to do a double embryo transfer, the live birth rate per transfer of 2 embryos has been 89%, and about 2/3 of those are twins. Of course, a longer discussion is the risks of twins. Twins are increased risk for really 2 reasons. Number one is that there's 2 babies, and so if either baby has an issue, that pregnancy is complicated by that. And then number 2 is that on average, twins are born about 3 weeks earlier than a singleton. So technically about 36.5 weeks is when the average twins are born. And technically anything prior to 37 weeks is called preterm. And so my twins, who are 9 now, doing their remote learning at home, they were born at 36.5 weeks and were 7.5 pounds each. But the concern, of course, is that sometimes those twins are born earlier than that. And of course, we could talk about that. Next, I think our last slide, it just talks a little bit about our experience. According to the most recent SART data that just came out, there were 2,500 surrogacy transfers. In that one particular year, we did over 10% of those. Our success rates I talked about before, but at least relative to the experience of the clinics that we see in our region, you can see that those clinics did single-digit numbers of cases where we transferred almost 300 2 years ago. And that's where a lot of our experience has come from. We're so lucky to have such an experienced team and have been such a big part of the surrogacy community, and we're really just pleased to be there. So thank you again so much for your attention, and thank you to the team at Circle for helping us deliver this.
Thanks. So I think you can stay live because we're going to open up first. There's a wonderful team at ORM photo. We're going to open up first on COVID-19, and I think, you know, obviously it's great to hear from the doctors, number one, because they've been probably impacted more than the surrogacy piece just on guidelines, et cetera, so they can speak to how COVID has impacted their current processes and what they're doing with patients. But also Dr. Massie happens to be in, you know, one of the initial epicenters of the Bellevue, Seattle area. So I don't know if you two both want to talk first, and I'll talk a little bit about how it's impacted from a legal process standpoint.
Yeah, sure. So one of the things I think to be aware of is one of my wife's professors, she has a master's in public health also, was talking, and I think Chris Cuomo said, what do you think of the US map? And I loved his answer because he said, there's not a US map, there's 50 maps in 50 places. And so, you know, a lot of us are experiencing this in a different way. And you know, my heart goes out to everybody. I hope that everyone's families are well, but it's changing week to week. There were a couple of different reasons why it's changing. Number one, the American Society of Reproductive Medicine, out of an abundance of caution, said, well, this is new. We don't really know much about what's going on. Maybe we shouldn't be doing transfers or inseminations right now. And so the majority of clinics, I think, have stopped that, at least temporarily. In a lot of places, fertility clinics are open, and in many places they're seeing more urgent cases, time-sensitive cases, which you can think of like a 41-year-old who's, you know, can't really delay because her eggs are aging. I think that as at least the West Coast starts to decide in unison how we reopen safely, there's a few things to talk about that. Number one is that we wanted to protect PPE, which is the protective gear that we have. And I think that as the weeks have gone by, the West Coast in particular has done a really nice job of being socially responsible and physically distant, and has gotten on top of what our hospitals need to take care of all of our patients. And so I think those restrictions will be opening up. So far, there has been no data that any of us on our team have seen that says that COVID specifically attacks women or pregnant women or babies. Unlike some of the other viruses out there that we know, like Ebola or Zika, there's no evidence that says that. So the caution was really just preventative. And because the time frame of surrogacies happens over many months, I think as a lot of the clinics start to reopen in May and certainly June, I think that we'll be able to get a lot of our patients back on track and onto similar timelines. It takes us about 2 months to create embryos. And so, you know, we have completely re-engineered our process to be able to do all of the IVF, whether it's an egg donor or a transfer, when we're open for all of those different populations in a completely socially distant way, so that no patient in our facility is ever near another one, because we don't want you to sit in a waiting room next to a patient that could be a risk of getting COVID from you or giving COVID to you. And we don't want to give it to you as providers or to be at risk of that as well. So hopefully it's not too much of a delay, and we really hope that we can get back on track to more normal activities in a, you know, different, in a modified way, in a socially distant way, but in a safe way as well over the summer. Dr. Massie, do you have anything that you want to add to that?
No, I agree completely. And I think, you know, as being part of the epicenter here, what we really have seen is that clinics pretty universally have taken steps in order to just completely revamp how we see patients. And it's taken some innovative thinking, but I really believe that the way that we have it set up now, as you say, we're bringing patients in, we're doing that in a way that's really socially responsible, that minimizes their risk and our risk, but allows them to proceed with the care that they need.
So I'll speak to it from the agency side. You know, we have two different sets of parents that are impacted. We have domestic and international, and they both have little intricacies of how they were impacted. I think right from the get-go, the biggest issues we faced initially were travel bans, both from China and then from the Schengen area, UK, et cetera. And now it seems like most countries there's travel bans. So, you know, as a team, you know, we met immediately, you know, different legal impacts, process teams, et cetera, met, and we immediately got working on assisting in getting as many parents here as possible prior to births through May. So currently, knock on wood, we haven't had anyone miss a birth. For those that are due in May and beyond, we're helping work with their the U.S. embassies in their countries to try and get an exemption around the travel ban based on the fact that they're having children born through surrogacy. And again, knock on wood, it seems to be working with most of the people that have applied thus far. The bigger impacts from a domestic standpoint for pregnant intended parents has been more of hospital situations where hospitals have a much stricter view on who can come in and out of the hospital. So, you know, there are cases where you've probably heard in the news that they weren't even letting surrogates have support people, or any delivering mother have a support person. So we've tried to, you know, help parents work through those aspects. If only one can go in, you know, work in some way, so the parents aren't impacted too much. But obviously, it's, you know, going to be a letdown because it's not what they expected when they went into this process. Both the surrogates and the intended parents are going to have some, you know, potential negative impacts based on that, you know, not being able to be there. But we've tried our best. We just had our another support group for intended parents that are all in similar situations, and it actually turned out really well tonight, where parents from specific countries, you know, got each other's information so they can help each other out when they're on the ground, and parents that have already delivered and got here are getting connections to help parents that are, you know, due in May and June. So it's been really cool to see not only internally our teams working together, but our parents and our surrogates. We've also assisted with putting together a surrogacy professionals webinar where different doctors are coming in, and mental health specialists and finance specialists, et cetera, just to give as much information out to the whole community as a whole. I think, you know, Dr. Bankowski and Dr. Massie will probably attest to it too, even their field, even though we kind of compete in certain ways with other agencies or clinics to clinics, it's one field where everyone kind of wants the best for the whole field. So right now it's been excellent to kind of help put together these relationships and help other agencies, help other lawyers with their clients to get through these processes, and, you know, just pass on any information we all have to get to that next step. So it's been, and we've been trying to do it every other week for our own parents to have, or intended parents to have an information session every other Friday, just so they can ask any questions and we can give any updates on what's going on from an IVF perspective, from a medical perspective, from a legal perspective. So just trying to keep everyone as informed as can be. People asking, should they start? Should they put things on hold? I mean, if you know you're going to do surrogacy and you think you're going to do it, I don't think there's a reason to put it on too much of a hold, because as we mentioned earlier in that timeline, there is going to be a waiting period to find your surrogate, to pick your donor, to pick your clinic, et cetera. So, if you get in and start the process, you may see a little bit more of a wait time to when you can actually do the IVF process, but you can potentially find your donor, match with your surrogate, complete contract, start building that relationship well in advance of when you're going to actually go through the IVF process. And I don't think it hurts. What we've tried to do as well with intended parents that are a little nervous potentially about the medical piece or the financial piece as a result of the financial crisis on top of the medical impacts of COVID is, build into the contract that, if they're nervous, they either pay in certain set amounts or they have a money back guarantee if something happens financially to them prior to being matched with a surrogate or donor, or if this drags on for a lot longer and they don't want to stay involved, they want to take cash out. So we've been flexible with our recent sign-ons to put in different clauses to protect them, and that's really basically kind of the overall questions. And obviously any other questions you have, both from a medical, from a process, from a strategy standpoint on COVID, feel free to start putting them in the question boxes. Basically the last topic is, how can you start your journey? Both Circle and ORM offer virtual complimentary private consultations Monday through Friday. We've been doing nighttime and morning and all day. I know everyone's home, and if you need a break from work and you want to talk about this process, or you need to do it after hours, we're happy to be flexible. We usually, most of us have set aside a weekend and evenings, as I mentioned, so we can be flexible with your schedule. Typically, both of us usually do a lot of in-person, but obviously due to COVID-19, everything is kind of virtual right now, and hopefully we go back to these in-persons in the summer or fall, but for the moment we do them through Zoom, through Skype, occasionally through FaceTime if necessary. And on the website, or in the slide here, you'll see, and you'll get this, but you can, if you want to schedule a consultation directly with Circle, you can reach out to Lauren Enterkin, and her email is there, lenterkin@Circle Surrogacy. And for ORM, you can reach out to Molly Huick, I hope I pronounced it right, which is MHUYCK@omfertility.com. And you can go both to our websites as well, and there's a place to set up or schedule meetings. So I want to thank all the panelists, all the presentations, and all the presenters, and all the people who've stayed on this long, but obviously there's also questions to come. So let me go back to that. I'm going to queue up the questions, and I'll go right through them. I'm going to make everyone live in case the question pertains to you, so everyone is off mute. So the first question is, can you please repeat the name of the third-party company for insurance? There was two. So there's one called Carrot, and there's one called Progeny. It's PROGYNY. If you're, like I said, if you work for a company with 500 or more employees, you can have your HR reach out to either Progeny or Carrot. I think Carrot, you can also do kind of a private reach out where you as an employer can do a kind of send them your HR, and they anonymously reach out directly to your HR to try and set up an appointment to put it in. But again, that's Carrot, like spelled like the vegetable, and Progeny, PROGYNY. For the lending, can an applicant be a green card holder married to an American citizen? I believe so. I'm not 100% sure. I will find that out, but I believe yes, as long as you're a resident of the United States, whether you're a citizen or not doesn't matter. I think as long as you're a permanent or a resident, you can do it. Can the entire process be financed? Not through the entity I mentioned, but there are other medical loan companies out there. They probably don't have as good of rates. A lot of people, particularly now that rates have been so low on home equity and mortgages, a lot of people, we'll look at a home equity line as well, potentially, because they may get better rates than any private financing. So there are different ways that potentially, yes, you could finance it certain ways outside of those third-party finance companies. Is it possible to dictate if you have twins through surrogacy, and if so, can you use the sperm from two dads? Well, I'll let the doctors speak again kind of to the medical complications, and no, it's not possible to fully dictate if you have twins. Yes, two different dads can create embryos and do implantations, but you never know if you're going to be successful on those transfers to begin with. But I don't know if Dr. Bankowski or Massie wants to talk again a little bit about the potential issues with twins, but we do know with biology you can't really dictate anything until it happens.
Right, exactly. So so if you were to decide to transfer, let's say, one embryo from each member of the couple, so two embryos together, the most likely outcome is twins, right? 65% of those live births are twin live births. However, nobody can make it be twins. And about 1% of those, one of the embryos does not implant, the other one does, and happens to split. So, things that happen out in the world, they happen in IVF as well. It's really a longer discussion that I think we have time for now, but just to talk about the risks. Not all surrogates that we approve necessarily are approved to carry twins as well. Some that are approved to carry twins don't want to carry twins. And so most important for us is to have enough information so that you can make a really informed choice as to what you decide to do. We have an increasing amount of intended parents that are actually choosing to do two different surrogates at not exactly the same time necessarily, but two different journeys, so that they can both become genetic parents, which is their dream, but do it in a safer way to minimize the risks. And so that is another option that a lot of our patients are choosing.
Question, I guess both of us could answer in terms of costs. Do you pay all the costs up front, or is it paid as you go? So from a Circle aspect, there are different payments along the process. So there's usually an upfront cost of agency fees and different potential or future screening and legal costs. There's a payment usually made when you match with a donor. That's the donor's fee and some of her expenses. And then when you match with a surrogate. So it's, if all goes well and you match in that kind of 4 to 6 month time range, you're usually funding the process in the 6 to 8 month range. And then obviously the clinic will have a different payment structure, but it's usually either, I'll let ORM speak specifically to theirs, but it would probably be inside of that same time frame.
Exactly. Yeah, you pay as you go through it, and then there's a package cost to start the big part of the process, which is the actual donor's egg collection. So, but yeah, the specifics we'll be happy to send anybody in writing so that you can see exactly what it looks like.
So medical question, can two sperm providers fertilize one egg? If it is the case, is that to achieve twins or a singular infant?
Dr. Massie, you want to take that one?
So no, you only can fertilize an egg with a single sperm. So if each partner wanted to become a genetic parent, then they would need two different eggs and fertilize each egg with their single sperm, usually like we talked about through the process of ICSI. Twins actually develop in two ways. One is if we transfer two embryos, each of them can implant and grow. The other way, which Dr. Bankowski alluded to, is that a single embryo can be created and then very early in the developmental process can split into two embryos which implant and grow, and that is how people get identical twins.
Question is the first process done to check the parents' fertility? So it would be a gay couple.
So the evaluation for the sperm donors, it starts with just a simple semen analysis. So that's just a test in which we take an ejaculated sample of sperm and we look at certain parameters like how many sperm are present and how many of them are moving and if they're of the normal shape. That's really the first piece in figuring out if the sperm have a good potential to fertilize eggs.
So this question, are there any known benefits of choosing a surrogate in Canada versus the United States? I don't know I think probably the big benefit of Canada over the United States has always been a cost analysis. Really, Canada has pretty strict specific laws on surrogacies that agencies aren't supposed to be paid to find surrogates, number one, and number two, surrogates have always had this, they weren't supposed to be paid, and the country always said they'd promulgate regulations on what expenses could be paid, and those regulations have now been promulgated as of last year, and it's very specific to what a surrogate can be reimbursed for. It's really only medical, travel, and other specific expenses, and it must be documented. So it's very hard to find surrogates in Canada. So when you're working with a Canadian agency or Canadian kind of in between, I think the wait time is a lot longer and the screening isn't as good. At least that's kind of the anecdotal evidence out of Canada. People have done it for a long time. It's worked, but I think there is that issue that it's tough to, from a population standpoint, it's tough to find people that you don't get any real reimbursement other than their actual expenses. Some of the provinces have laws where really the surrogate potentially has a 7-day window to change her mind and keep a child, but I don't know offhand of any cases where surrogates actually done that. It's just, I think the way the law was set up, there was this 7-day kind of waiting grace period in a sense. I don't know, you can, if you're looking into it, you can ask their specific wait times and ask to speak to parents that have gone through the process, but there's the potential that the wait time could increase even more now that there are these specific regulations in place for costs or for reimbursements to surrogates.
Yeah, and Dean, I might tell one quick story to highlight a little bit of the challenge as well. Our patients have struggled so much in Canada, and some are just starting over after 2 years. But if I were to review a surrogate, let's say she had 3 children of her own that were in grade school and she wanted to be a surrogate, and you guys were to send me the records, my team would probably be reviewing from her medical history and her 3 pregnancies, probably if you were to print out the electronic medical record, somewhere between 200 and 300 pages of everything that was done to evaluate her during that process. If I were to review a very similar candidate from Canada, I would probably get a third of one page paper with a third of written on saying 3 healthy pregnancies approved for surrogacy. So it's not that that's not true. It certainly might be true, but it's so difficult for us to feel good about the surrogates that come out of Canada because we know so little about them, and their entire system of medicine is completely different than what we're all used to having available to us in the United States, and so it makes it really hard, and we really don't recommend the process in Canada. We just can't really get behind it medically.
Yeah, I mean, the other thing I would add too is if it is something you're thinking about and you decide to go that route, definitely create your embryos in the United States and use a US-based IVF clinic, because if you run into one of these situations where the wait time is really long and you want to get out of your Canadian surrogacy, if you created your embryos in Canada under FDA rules, you're more than, I mean, the doctors can probably speak better to this from their clinics, but unless it was created for your own use outside of surrogacy, you really can't import embryos into the United States. So you may waste money creating embryos there, and you have to restart the entire process in the United States.
And also, as you can see from the SART statistics, which is a voluntary database, but it's audited, there is no such database in Canada. So while there are huge differences in American clinics, we really know nothing about the success rates of any clinic that's in a different country, because that same structure of audited success rates doesn't exist.
So question, does Circle work with couples that just need an egg donor because they know someone who wants to be their surrogate? So, I mean, yes, I'm sure Orem has the same answer. Yes, we have a separate egg donation agency. So if you only want to use us for egg donation, you don't need to use us for the whole process if you have a friend who wants to be a surrogate. Let's see. What do you suggest for same-sex couples who are planning to have one biological child for each of them, one at a time, use same surrogate twins? I think we've heard the medical piece a couple of times now. I would say our usual advice is one at a time. And if you can wait, use the same surrogate a second time. Obviously, there's no guarantee that she'll be able to carry the second time if there's a medical issue or something comes up during your first journey. But I think a lot of our intended parents who signed on to do what's called dual journeys, where they'll transfer an embryo to one surrogate, wait a certain amount of time. If there's a pregnancy, then they potentially match with a new surrogate and do a transfer a little bit later on. So there's a time difference between the births, and they're available to both their surrogates, both mentally and in terms of being there for the births. A lot of them end up starting that way, and then suddenly they get into this first process, they get pregnant, and they say, wait a second, we love our surrogate. We don't really want to be involved in 2 of these cases at once, so let's just wait till we have the baby. If we can work with our surrogate again, we'll work with her. If not, we'll then just start the matching process again, and we'll, have a couple years to become parents to one child first to see, to make sure we have it all down. And this way too, usually the cost savings are greater when you're coming back with the same surrogate a second time, because the legal work will be similar, the legal contracts will be really similar. There's greater discounts from an agency perspective, from a medical screening point usually too. It's a little less intense in terms of the fact of a brand new surrogate coming in that's unknown. So we usually try and stress that, partly because for all the reasons, the twins aren't the best pregnancies usually anyway, and they're a little more challenging for both the surrogate and the babies and the intended parents. And on top of that, it's getting harder and harder to find surrogates who really want to carry or willing to carry twins, because they understand the greater risk to their own bodies and health by carrying twins.
I think also, Dean, that brings up a really good thing to talk about, which is oftentimes in a same-sex couple, one person might have a stronger drive to get started. And I hear very frequently, well, I'm not sure if I want to make embryos or not. I think I'll wait and we'll have the donor go through a second time if that's what we decide. And I'd say to all my patients that I'd really consider both of you making embryos right off the bat, because there have been a lot of times where 3 or 4 years down the road, that second partner says, I really do want to do this, because you see that child that you're raising grow up, it looks like your partner, and that becomes important to you. But if the donor has retired or has moved on, or if she's married or pregnant herself, or maybe she just doesn't want to do it anymore, those options might not be available to you. So we can keep the embryos cryopreserved in liquid nitrogen for many years without any change in the success rates. And so even if you both created embryos, you may choose preferentially for one person's embryos to be transferred first, even a second time, a third time, while we keep those others frozen. But that option might not be available to you down the road. And for many couples, same-sex couples, it is important that their children share genetics through the same egg donor. And doing that upfront makes that possible with a lot more security than potentially waiting a couple of years. So just something to think about.
So there's a question, is there an extra cost for twins? So in terms of because our program is fixed in nature, there is an added cost if you go a twin route and if you get pregnant with twins, just because there's higher risk of everything, including all the kind of third-party expenses and the contingencies that can happen during a twin pregnancy. So yes, there is a higher cost associated with it. And the other thing you have to think about, some of the hidden costs that people don't, if your twins are born early, like we've already talked about, that the average is they are early and they have longer stays in hospitals, that there's the potential that, whether you're domestic or international, you're most likely traveling to another state for the birth. And you could be, a month, 2 months extra staying in hotels, eating out, waiting to get home. If you don't have the best dependent coverage out of state, you might have higher medical bills, et cetera. So there's third party out of cost that you should think about from a twin perspective too. What I used to tell a lot of people, and I still do, is a lot of times people will wait longer to match for twins, and there's no guarantee, like we just talked about, that you're going to have twins. So you may wait an extra 4 months to match with a surrogate to have twins, and then suddenly find out you do the transfer and you only end up with a singleton anyway, and you could have been halfway through your pregnancy or longer. So there's that time issue too.
So I tell everybody, if you think about twins, just think about this: 1 is 1 and 2 is 10. It's not linear math, it's exponential math. So those costs continue after the babies are born because you need 2 of everything at the same time. You need a lot more help. You're getting a lot less sleep. So don't just think about it as costs during the initial process or during the pregnancy. Twins are a lot more expensive. They're wonderful. I wouldn't want it any other way, but it's important to think about that.
Yeah, I think we have 2 former surrogates at work at Circle that carried twins for intended parents, and we have a Circle coordinator who has her own twins, and they usually like to talk to intended parents that are really focused on twins just to give them their own real world experience of what it was like. So there's about 20 questions and 1 comment, so I'll try and get through all of them, and people can jump in where they should. Number 1, are the initial consultations free with both Circle and ORM? And the answer, I think we put it in there, but yes, both consultations are free. They're no cost at all. So if you want to schedule one, go to our website or reach out to Lauren on that email address we had mentioned. What would be an approximate cost of the full process, including egg donor and carrier? So with the fixed nature, obviously depends on what type of IVF package you choose, but you're probably somewhere in the, I'd say, 185 to 210-ish, depending on, the surrogate's fee, the donor's fee, what you choose from an IVF perspective, which program you choose at Circle. So it really depends on some different factors that could come into it, and obviously we can go through it when we have that consultation. And I don't know, Dr. Bankowski or Dr. Massie, if you want to give a range of your IVF costs, but obviously there's wholly different packages available, not only from a surrogacy piece, but from the IVF clinics too, where you can just kind of do IVF and do a transfer, or you can get these big package plans as well.
Yeah, I think referring to the website is probably the best, just because it's all written down there.
Yep. Same thing. We have a financial tab on our website. You can download a full cost sheet. So egg donors, when they go through genetic testing, is it just finding medical issues, or can it ID past mental health history as well?
I think there's a little bit of a tricky question, because some of those issues, such as mental health disorders, are what we call multifactorial. So there's a genetic component as well as a non-genetic component. The goal of the testing is really to identify any hints in the prospective donor's history or family history that could suggest that that's an issue. And as Dr. Bankowski said, one of those examples is something like alcoholism, which is considered a mental illness. And we don't see that in every single generation as we might with some genetic conditions. But if you have those things in your family, then you're considered to be at higher risk, or your children are considered to be at higher risk. So while it's certainly not a line in the sand, the goal is to really just evaluate patients' histories, figure out what their risk profile is, and then make decisions based on that information.
If an IP has HIV and planning to provide their own sperm, is the process more expensive if it is the case? So I know there are third-party entities. There's it's called the SPAR program, Special Program for Assisted Reproduction. There will be an added cost for the kind of screening, the testing, as well as the sperm washing. I don't know if any clinics do it separate, but I know there's Bedford Labs out in Massachusetts, which does a lot of these cases, and they do the initial sperm work and then send it to a clinic like ORM to do the IVF process. I don't know if ORM has their own sperm process, or you work with Bedford.
We've always used Bedford, yeah.
Okay. So it will add some costs, not a huge cost perspective, but it will add some costs to it. And then, is this process viable for a family with a certain level of earnings, with a mortgage and other expenses? I mean, at least reach out and talk. There's ways to do it. If Circle can't help, we can refer you to other people, but there are other grants out there and charities that can potentially assist, and we're happy to have that discussion. All right, let's see. So medical question, does the ability to select the sex of your embryo exist? If so, how does that work?
It does. So part of when you get your report from your pre-implantation genetic testing assessment, each embryo is given essentially a reading or a report or result, and that gives you both the biologic sex of the embryo and whether the embryo is chromosomally normal or abnormal in terms of the number of chromosomes present. So some people choose to have that information disclosed for them. They want to know what the biologic sex is. Some people do not. So don't feel like you have to go one way or the other. If it's information that you would rather not have, then all you have to do is let our team at ORM know that that information can be essentially blinded from your end of the report. So then what you'll see is how many genetically normal and abnormal embryos you are, minus their biologic sex.
There's a question on how long the PGT process usually takes.
So the embryos are biopsied on both days 5 and 6. So once they meet criteria, they're biopsied, and then it usually takes between 10 to 14 days to get those results back.
Let's see, for Circle, are there any cost fees that are not included in the fixed cost program? So the only fees outside are usually costs associated with the child's costs at the hospital. So the baby that's born, and that's either usually through your insurance or whatever deductible you have. Your own travel, so your trips to visit your surrogate to do your IVF and for the birth of the child. And really those are the only two, that we keep outside. Everything else related to the surrogate, the donor, in the process. And obviously IVF is outside of our fixed, but clinics like ORM have their own kind of package plans that basically create an unlimited or a fixed in nature program on top of ours. So you can fix it all in a sense. Is it possible to bring frozen blastocysts from Europe to the US to transfer them to a US surrogate? So from the legal perspective, and the doctors will speak about it from their own regulatory side, but it's usually only possible if they were originally created for your own use using your own sperm and egg, and then you have to move to surrogacy, and the clinic will still have to get an FDA waiver from our Federal Drug Administration in order to use them. But the doctors may have more of a better answer from their own side, from the clinic side.
Yeah, I think that's a complicated one. It depends a lot about the specific details of the situation. So I would discuss that with your clinic.
I think those are repeat questions. On a worst case scenario, does Circle have any connections to sponsors that are willing to help with costs for couples that want to have children? As I said earlier, reach out. There's different grant programs and charity programs out there. It depends on, for same-sex couples, there's an entity called Men Having Babies that has lots of different, it's called the GPAP program that helps those couples. For hetero couples, there's different grant programs through Resolve and other entities. So we're happy to at least point you in a direction to find potential assistance that way. And that was the last question, so I'll keep it open for another 2 minutes. And as I'm keeping it open, I want to thank everyone who stuck through for the whole conference. I want to thank Dr. Bankowski, Dr. Massie, and Nancy for their presentations. I hope we were able to provide a lot of the information you were all looking for, and please hopefully reach out to us and to ORM to have a private consultation to speak more to your specific case. That looks like it. So thank you, everyone, and we hope to hear from you soon.
All right.
Thank you so much.
Dean.
Thanks, Dean.
Thank
Thanks,
you.
guys.
Have a good
Bye,
night.
everybody.
Bye, everybody.
Bye-bye.